Okay, good evening, everybody. We'll get started. Just starting a couple minutes late. My last lecture for my other class just finished, so I was in a hurry to get this one up and running. So forgive me for getting stuff going here, but I want to be up and talking. Welcome to week 3. Happy Memorial Day, vets out there, and those of you that know veterans. Let them know thank you for me for the sacrifices that were made, and a day that I think gets a little bit forgotten because it's just another day off, but that's just my soapbox for the day. Anyway, welcome to week 3. You've got your first 2 weeks underneath you. And as I've said with past 2 weeks, I really enjoy reading your discussion posts and what you guys have been experiencing with your clinical time. And really impressed at some of your experiences. You guys are seeing some really great things. And it's fun to listen and see or read and see that you're growing, you're learning. Your preceptors are letting you guys do stuff, which is awesome. That's a reflection of you guys, that you're working hard, that you're paying attention, that you're asking good questions. You're doing all those things that I spoke of on week 1 that I watch for in students. And I'm the first to admit, if I have a student that's working hard and paying attention and being engaged, then yeah, I'll let them do stuff because I'm comfortable, because I know they're paying attention. And I can see you guys are getting some freedom with some blood gases, bagging patients, doing breathing treatments, doing assessments, meeting with your physician, interacting with your physician, all those things, and that excites me, and that is what we're here for. Overall, I think your discussion posts are great. Keep in mind to keep those of proper length, and make sure that you're putting some substance in there. If you didn't have a really busy week, talk to us about something you learned from your reading, things of that nature. Been a little lenient on the first couple of weeks if you haven't put much there, but start thinking about something to post with some substance for us, so that we can learn from you. I think that's a great item with IU, is these discussion posts. You can learn from each other. Some of you have asked questions of me, and that's great. It's a great opportunity for us to all learn and grow together. And, I look for opportunities to learn from you as well. So make sure you're posting those. And then more importantly, or not, I should say more importantly, but importantly nonetheless, is that you are not only doing your very own primary post from your lessons and your experiences from your clinical time, but also that you're posting to at least 2 other students sometime during the week. And that's giving you guys all the opportunity to learn from each other. And I enjoy reading your posts. I enjoy commenting on your posts. Once in a while, I might give you a little question to get you to think a little more, or to review the experiences you've had. So keep up the good work. This past week, our first physician interaction was due, and overall, I was really happy with everybody that was able to get those in and got them in correctly. If you remember from week 1, we kind of worked really hard on making sure that you had some exposure to that in the actual physician interaction post in Canvas. There's some slide-by-slide pictures that show you what needs to be where. There's also, I showed you a YouTube video that I had the sound messed up with, but I did share the link with you in a course announcement that you can click on and watch the YouTube video. And then there are resources for you. Myself, the co-instructor, that she's an administrator, but we list her as instructor for this course, is Annalise Savage. She's the one that gets your submission, and she looks at VeriSign and makes sure that your signature is proper, that your preceptor's signature is appropriate, and it gets sent back to you, and then you submit it to me. Also keep in mind that you need to write up, because it is a physician interaction, you need to write about your interaction with your physician excuse me, from the week's previous clinicals. That needs to be a good statement explaining to us what you saw, what you did, what you learned, things of that nature. It's something that can't be taken care of with just a couple of brief sentences. If I do see just a couple brief sentences and not a lot of substance to that, I will typically just say, hey, I'm not going to grade this yet. So if you want to resubmit back to me a little more so I can get a feel for what that interaction was, what you learned, and how it impacted you. That's really important for me to know that you're getting something from those interactions. So don't worry about being deducted for being late. As long as you get it to me, we'll go from there. We know that everybody has different clinical times, things of that nature, so we're a little more lenient on the due dates with this particular mod course. But keep in mind that if you don't have that in yet, let us help you. Let's work together and figure out. And oftentimes you have the paper done and it's good to go, but we're having a problem with email or your preceptor isn't getting it. Get in touch with myself. Let me know. I'll pass it on to Annalise. She is a whiz at doing this. She's very good at it. And she usually can get in and figure out what the issue is, whether it's on your preceptor's end, your end, or IU's end, and she'll fix that. Another option is the online tech. The IT department, the tech support folks, they're an excellent resource as well, and they can help you as well. So keep that in mind, and let me know if there's something I can do to help you in that regard for those physician interactions. Like I say, for the most part, most of you got that stuff in. So those of you that haven't, or you're having issues with it being Memorial Day today, I'm sure Annalise isn't in the office today, but tomorrow, let's do what we can. And I've been in email contact with a few of you over the weekend, and we can get that taken care of. So if you have issues or questions, please contact me and we'll get it fixed. And this might be unique. You haven't seen this before because, last mod, you didn't have to do it. You just signed it and faxed it in or that sort of thing. No, this is the new way that I use doing it. So even if we're having issues, I'm okay with taking a couple extra days and let's get you figured out and get you used to doing this and comfortable. I'm okay with a couple extra days delay to get it in, so you know how to do it, because for the subsequent clinical courses that you have, it's all going to be in this format, in this way. So I'm okay to work with you, and let's take our medicine and get it figured out so that you know how to do it for the rest of your IU experience. Also, just a quick word about classmates. I can see that a few of you are taking advantage of that. That's excellent. I'm thrilled that you are. That's wonderful training. It's good preparation for the clinical portion of the TMC exam. Remember, all in all, the reason I'm here, the reason you're doing clinicals, the reason you're taking these courses is, yes, to get a degree, but more importantly, to take and pass that TMC exam, and more importantly, at that higher cut, so that you can take the clinical, be an RRT, get your license, and work. That's what we're here for. That's our goal. That should be your goal. And don't give up until you get to it. Like I said, week one, it's been very rewarding for me. I'm so glad I made that decision years ago to enroll in the respiratory program at Weber State University and get my degree. And now I'm getting paid, and that's what I want for you guys as well. So without further ado, let's talk about what we're going to talk about this week. And like I say, if you guys have any questions, let me know. There have been a couple of questions. Maybe I'll just maybe address a couple of those from the discussion or from email or what have you. There's a little bit of discussion about trach tubes or tracheostomies and different types of trachs. For the most part, there's two major manufacturers of trach tubes or tracheostomies. One's a company called Portex, which they make lots of different respiratory parts and fittings and stuff like that. They do make trachs. And then the other brand is Shiley, and then a smaller brand is Bavona. They all have their different niches and kind of the different stuff they do. Shiley's pretty predominant. They're plastic trachs. They have a disposable inner cannula you can change out. Some are non-fenestrated, some are fenestrated. When I speak of fenestrated, that means that they have additional holes in the tube, so that if you put a button over it, that you can utilize part of that tube to pass gas up into the upper airway. So that's something you guys can look at, is fenestrated trach tubes. So that's the Shiley. Portex is similar to the Shileys. And then someone was, I can't remember who it was, had a question about extended length trach tubes. Based on our population, we're seeing more bariatric patients. And so we're seeing more tissue in the neck region. And the good old Shileys that we've had over the years may not fit through all that tissue into the trachea. So Bavona is an extended length device. They have adjustable length, they have fixed length, but they're longer and they're fairly flexible. They have a wire that's down through that tube to prevent it from collapsing, to give it some additional strength, but it's fairly flexible. They're nice devices, but they don't have the inner cannula you can change in and out. So if someone coughs something into that, or you get an occlusion, you have to clear that trach out. You can't just pull out the inner cannula and throw it away and pop a new one in like you can with the Shiley and the Portex. Shiley makes their own version of extended trach tubes. It's called the Shiley XLT, and they have what's called the distal and proximal Shileys. And so the proximals means that the distance from the flange that's outside the neck to into the trachea is longer, versus the distal, which is longer down into the trachea. So those are the quick overview based on, a little bit on the discussion board this past week. We had some questions about some tracheostomies and trachs. All really good products. I spent time with them with multiple patients with multiple, everybody using those different devices. And so I've spent time with all of them. They all have their good points and their bad points. But thankfully, the manufacturers are keeping up with our population as we have a increase of the larger bariatric size patients, where we need additional specialized tracheostomies for those chronic patients that need them. So some stuff you can take a look at. Take a look at when you're have some time on Google. You can look at those different trachs, or watch for them in your clinical time. Maybe your preceptors can tell you. So this week I thought we would talk a little bit about humidity and how we can provide humidity to our patients. And how we can provide humidity to our patients, one, and also heat that gas, two. And I'm sure that as you've been in your clinicals, and most everybody's talked about dealing with intubated patients, because we're bypassing that upper airway or that nasal pharynx, which that's the primary job of that nasal pharynx. That's why it has that arch and has those turbinates and has the hair and has the capillary beds, is as we suck and breathe in through our noses, by the time it gets down to the glottis, that gas is typically heated and humidified to body temperature and 100% relative humidity, so we don't dry out our lower airway. And when we start dealing with high flow systems, if we're not heating and humidifying that gas to our patients, we can dry out that mucosa really quite quick, and we can clog off our artificial airways in our patients, and patients can succumb from that. I've got a story that I'll share with you as we start into tonight's discussion of just how important that is for us to make sure that we're providing proper heat and humidity to the airway so that we don't dry out secretions and mucosa, to keep, one, our patients safe, but two, so we don't cause any harm. I have over the years moonlighted at a long-term acute care hospital, and if any of you have an opportunity to do any time there, it's a good experience. That's where you have patients from the acute hospital. It's still a hospital. We still have an intensive care type unit there, but the average length of stay at these hospitals is about 25 days. And those patients at that point are either intubated, need to be trached, and we trach them there, or they've just been trached and then they get sent to us. And our goal is to get them off the ventilator and get them decannulated, and get that trach out of them. And I enjoy that work. I enjoy acute hospital work, and I do like the long-term acute care hospital work as well, because I like the challenge of weaning those patients that they haven't been able to wean at the acute hospitals. Having said that, one morning I arrived on a patient report, and it was a ventilator patient. She was intubated. She was shipped from a facility that sent her to us for continued weaning. They felt like she might have potential because she was a reintubation for being a long-term patient. And so our goal was to see if we could get her extubated and keep her extubated. If not, and if we had to reintubate her there, then she was going to receive a tracheostomy and go long-term. However, as I received report, the RT that evening said that she had taken a turn for the worse. She was now on high vent settings, had difficulty ventilating, had poor blood gases because of her difficulty ventilating, and they were calling it more of a ARDS type pattern, high peak pressures on the vent, and having a hard time getting gas in and out of her. Therefore, her CO2s were high, her pH was low, and the night crew and physician felt like maybe the family needed to travel in and they needed to make decisions about whether they wanted to continue heroic efforts to keep her alive on the ventilator. Or in other words, perhaps maybe putting her on comfort care. I was like, wow, that's a big deal. That's not what I expected this morning with her. So as I got a report and finished, I always take a quick lap around the unit, and I always look in on all my vents at the very start of the shift. And the first thing I always make sure I do is look at the patient, and then I look at my equipment. And that's something that's important to me, that we treat our patients, not our equipment or our machines or our screens or our monitors, but actually look at the patient. And I could see that she was in respiratory distress, even though she was on the ventilator and was not getting adequate gas in and out of her. She was unconscious, wasn't doing a lot neurally because of her high CO2s, is what I perceived. She was coughing. I proceeded to try and pass the suction catheter down her ET tube. And as you notice, if any of you've had the opportunity to look at a suction catheter, they've got numbers down the side. And the ET tube has numbers on the side as well. And so what I like to do is be a centimeter difference from the ET2 numbers versus my suction catheter numbers. And what that does for me is provides for me that I can see where the tip of my suction catheter is in relation to the tip of my ET tube. Because I like to be at least a centimeter beyond the ET tube to apply proper suction and know that I'm out into the airway and not just in the ET tube. As I watched my numbers and expected where I should be for the tip of my suction catheter to be a centimeter beyond my ET tube, when I got to 30 and 30 on the ET tube, the suction catheter stopped and I could not advance it off the end of the ET tube. If you have that phenomenon happen, that's a dead giveaway that you have an occlusion on the end of your ET tube or trach. And so that's why it's really important to watch your numbers and make sure you know where you're at. I tried a couple of times to push through that, couldn't, so I instilled some saline down the ET tube to see if I can moisten up. Immediately the patient started coughing. I started getting chunks of secretion up that were about the consistency of cookie crumbs. They were so dry. As I instilled a little more saline down the ET tube, suddenly the patient coughed and up came the ET tube, a dried piece of secretion that was an exact relief of that ET tube, to the point that my suction catheter couldn't get it, but I unhooked the circuit and actually grabbed it with my hand. And it was hard in the consistency of, I'd say, something like a cookie. Okay, so immediately hooking up the ventilator, the patient took a couple of enormous breaths, and throughout the rest of the day, I weaned this patient, and that patient that afternoon was subsequently extubated from the ventilator and from the ET tube, was extubated and did fine for the rest of her stay. So in a 10-minute block, we went from a patient that was going to go in comfort care, her family was on her way in to say goodbye possibly, to dried secretions that need to be suctioned and the patient's extubated and fine. So why do I relate that story to you? Because the well-meaning RT, when they set the vent up, they actually set the circuit up so that it wasn't receiving humidity in the right direction from the ventilator. And over the course of the few days the patient was on the vent, we had dried her secretions and her airway out to the point where she was not ventilating properly because of obstruction of the ET tube. Little silly things like that, my friends, is how we can do harm to our patients. So please, please, please make sure you treat your patient, not your device, not your monitor, and look at the patient and look at the information that's being provided to you as you take care of your patient and make correct decisions. And as I was able to trace that system and got humidity back to her airway, she did very well. And like I say, she was extubated later on that day. So good lesson for me. I'm glad that I was there and able to intervene on her behalf so that she ended up doing very well. So let's talk about humidity today. It is important. Hopefully that story helps you to kind of gain appreciation for humidity. But relative humidity is the amount of water vapor in the air expressed as a percentage of the maximum amount the air could hold at a given temperature. The ratio of the actual water vapor pressure to the saturation vapor pressure. So saying all that can really be described in right here. So here is relative humidity, and notice at 10 degrees Celsius, that water vapor there is 100% humidity, but we know that a warmer gas can hold more humidity or more water vapor. So if we double that to 20 degrees, notice that 100% humidity drops to only 50% because there's more water vapor carrying capacity in warmer gas. And let's say that we triple that from 10, now we go to 30, then it almost drops in a similar ratio down to 28% relative humidity, because again, that warmer gas can hold more humidity. So as we provide humidity to our patients, if we heat that up, that gas up to body temperature, that provides us our max amount of water vapor we can provide to our patients to make sure that their secretions and their mucosa is not drying out. So there's lots of devices out there on the market. So let's just take a look at some of those out there, and we'll talk about what they do. So some really inexpensive, not very exciting devices. The first one here is a bubbler. The bubbler does nothing more than allow oxygen to flow through a vessel of sterile water. As the dry gas or oxygen from the wall or the tank flows up through the water, sterile water, it takes on a small amount of humidity and provides some comfort to our patient. The humidity amount is low, and we typically just use this in like nasal cannula type patients, and it's really effective for 3 flows of 3 to 6 liters. Any flow below that, there's usually not enough gas flowing through there to really make a difference to the mucosa. We put them on everybody at my hospital, regardless of their flow. Sometimes it provides a little bit of placebo effect for them that makes them feel feels better to them. But certainly on those 4 to 6 liter flows, we like to have a bubbler there so we're not drying out that mucosa in their nares. So there's your bubbler. This is for like a long-term or home type setup where we're doing it's still single patient use, but something we can add water to periodically versus disposable type. And this is what most hospitals use because it is single patient use. It gets tossed after each patient. We're certainly not going to clean and pass this on for sheer economics and for chance for transferring disease. And this is most bubblers you're going to see in a hospital facility, which I'm sure you've seen in your clinicals. This is a large volume nebulizer. This works off a Venturi valve. We'll fill water up in the cylinder there, and then that Venturi effect, as that gas shoots through there and creates a negative pressure and entrains more air, that gas is going to flow out this large 22 millimeters in this direction here. This is our Venturi port. Remember Venturi effect. As that gas shoots down through this smaller orifice, it has to increase in velocity. As it shoots there, that increased velocity creates a negative pressure, which draws additional gas in there, and in this case also draws humidity, where it mixes up in this chamber and passes out here to this patient. And so it's a cool mist, similar to a nebulizer if you've seen these in your clinicals. The nice thing about this is we like that cool mist humidity for your post-op tonsillectomy patients, for your nasal surgery patients, for your croupers, things of that nature. We like that cool mist and provide soothing to those patients, throat surgeries, things like that. Even a patient that's been intubated for a while, that cool mist feels good to them. But large volume neb, more of a particulate type water going to the patient, but nonetheless a way to provide humidity to our patients. Aerosol mask, so we'll just use blue corrugated tubing from that 22 millimeter tubing to the aerosol mask, and that's one effective way that they can breathe that cool humidified gas to that the patient can breathe that in. This is a face tent, similar principle in that that patient can breathe in that cool humidified gas. The nice thing about these is if a patient's had some oral surgery or surgery on their mouth or chin or jaw, this can be quite uncomfortable to them, or on their nose even, because of the pressure of that rubber band elastic around the back of their head pulling that mask on to hold their face, and so they have some pain there. We can result to this where it's not really pushing on the mouth or face or nose at all. And so this is a nice tool. We don't use these very often. I bet you we use 1 to 3 of these a year at my particular facility. But it's one of those things, when you need it, and provides quite a bit of comfort for your patient. So here's the T-piece. Again, now we have an invasive airway. As a lot of you have seen, there's lots of different ways to put these together. We use the T-piece Ballards at the facility I work at, or I should say facilities. And that allows us to have an inline suction as well. But we need to provide humidified gas to these patients for the same reason that we worry about our intubated patients, and like the patient I started off tonight with, how we can dry out her mucosa and her secretions where it blocks out the airway. So really important to provide sufficient humidity to these patients, because we are bypassing that nose that does such a good job for us. So we need to make sure that we have humidified gas going to this patient. Anytime you see a blue cuff like that, that's typically on a vortex trach. So we have some nice devices out there to provide not only heat and humidity to us. And like I say, I'm not here to sell any particular device, but I'll just show you some of the things that are out there. The two big players in the game is Fisher-Paykel, and the other one is Hudson Teleflex. Fisher-Paykel uses this particular style of humidifier. This is called a passover humidifier. So when we talk about passover humidifier, the gas is going to come in this side. This is a heat plate here. There's water in there, sterile water. The gas is going to go in there. We've got heated water here from the heat plate, and what it's doing is it's evaporating. The gas, dry gas, comes in, picks up that evaporated water, and that gas is heated and humidified and passes out that end and flows to the patient. Like I say, this is a passover humidifier. it's not as efficient and doesn't approach the humidities that the other style of humidifier uses, which is a wick humidifier. But nonetheless, it does a pretty good job. It has good technology. This particular one has just on-off switch, and then you can adjust your level of temperature. And remember, the higher the temperature, the higher the humidity. If you remember those initial slides, we're talking about relative humidity. The warmer the gas, the more humidity that gas can hold. I wish I could draw better, but I can't. Forgive me. Okay. So this is a wick humidifier. This is the Telflex Hudson brand. And we'll just give you another picture of this in a second. Here goes my handy drawing again. So now that dry gas comes in from the ventilator or from the wall or wherever it's coming from. In this chamber is a wick. And so you think about wicks. Think about a wick for like an oil lamp or something of that nature, where it's going to have water in this chamber, and that wick is going to draw that water up in here. It's also heated. Notice this is all metal. So this is going to drop down into a heated chamber. So as that gas comes in, it hits and flows across that wick, who's pulling that heated humidity up in there and then out to the patient. You may have seen these in your clinicals if that particular hospital uses this brand. These tubes here, there's a water box here, and I believe I have a picture of that. And so these will plug into their ports respectively, so that water is flowing in a circle like this as it flows past that wick. Most vent patients on this particular device, you have to change that water out about once every 24 or so hours. And it's about 600 cc's of water, if I remember correctly. So anyway, those are your two major styles of humidifier out there. The Fisher by Kell, which is a Passover, and the Telflex or Hudson, which is a wick type humidifier. I recall, and like I say, it's been 15 years ago when I took my MBRC exam. There was a question about Passover and wick humidifiers on my exam. So it's something that the MBRC and ARC are interested in. So as far as wick continued, this is a high flow nasal cannula made by the same company, but I wanted to just show you the interface. That particular chamber that I showed you on the previous picture, it drops down through the middle of this. Here's your controls here to turn on the temperature and the temperature gradient so that you can control your relative humidity. There's that box of water. The top tube plugs into the top, the bottom tube plugs into the bottom. That circulates that water as that gas flows in one end and out the other. In this case, it's a high flow nasal cannula. So that is the Hudson wick device there. And again, not providing commercial for anybody, just showing you what's out there. So we have circuits, and those circuits are, that's a good old 22 millimeter respiratory fitting. And that's what hooks up to either our Passover or our wick humidifiers. Notice this particular circuit doesn't have, when I say non-heated, it does not have any heater wire. It does not have a heater wire flowing up through that circuit. So when that heated humidified gas comes to this circuit, the temperature is lower than the heater. And remember, the colder there is the less humidity it can hold. So if we have warm humidified gas hitting cold air, it's going to create a cloud almost and condense, and we get rain out. So this tubing is going to fill up with water. And thankfully we have the technology to have humidified, but this is called rain out. And so we have hot humidified gas coming off the humidifier hitting a cold circuit. It's not the same temperature. And so that cold gas causes that water to condense. So the patient doesn't get as much as they could have. And a lot of that humidity rains out. So we have to keep these lines clear of water. And so it's a lot of work for RTs. So when they came around with heated circuits, which this particular circuit is, we have 2 cords here that hooks to the humidifier, and you can kind of see the wires inside that circuit. There's the wire right there. And it goes from one end to the other, and it heats and keeps this circuit warm. And so that hot humidified gas comes off the heater and flows up through this circuit. Everything stays the same temperature until it gets here to the patient, which is just beyond the Y, the hookup. At that point, you might get a little rain out because you might get a little bit of temperature change right there, but it's not much. The beauty of these devices is we don't get that rain out, so you're not spending your whole shift keeping water cleared out of the circuit. And so it's really a nice system. And Hudson and Fisher-Paykel both make them for their devices. They also have here and here temperature probes, so that device knows, okay, there's the temp here, here's the temp here. I'll turn the heater on or off to make sure I maintain that same temperature so we don't get any sort of positive or negative temperature gradient, so that gas stays at 100% humidity when it gets to the patient. Really a nice system. And when you get a chance in your clinicals, if you haven't seen it yet, make sure you hit your preceptor up and see if they'll show you these particular circuits. They both have similar heater wires, obviously different types of hookups to their heaters, but nonetheless, the principle is the same. Another way to heat and humidify that gas is this is a high flow nasal cannula, and it has a chamber inside there that the gas flows across similar to a wick, and that gas stays heated and humidified until it gets to the patient. The way that this device heats its circuit is it has circulating warm water throughout it, and that keeps the circuit warm. And so when it gets, that cannula gets to that patient, they don't get water spraying on their face from rain out, which if that wasn't working, that's what would happen. And I've seen these and other brands of high flow cannulas have issue. And what that does is you'll see almost straight water blow out the end of these, which if you can imagine sitting there with a nasal cannula and having water blow into your nares, not very comfortable, but yeah, once in a while these will not work correctly, and you'll get that, and you'll have to change out the circuit. Obviously you can see that she's happy, he looks happy, whether he's happy that the gas is flowing comfortable to him or that he has a blonde taking care of him as an RT. I don't know. I'm not going to speculate on that. I'll stop with the dumb jokes as well. But anyway, this is a high flow nasal cannula. This is a Vapotherm brand, and that's how they provide the heat and humidity to them. Prior to that, most hospitals start off with an HME. Sometimes an HME is called the artificial nose. This particular HME has, and most of them have some sort of membrane or something in there that allows the patient to keep the heated humidified gas that they're producing in their airway on their side, and the cold dry gas coming from the ventilator on its side. So If we go back to my lousy drawing, this is kind of the line of demarcation. We have the cold gas coming in from the ventilator, and we have the heated gas on this side, and this membrane allows the gas to pass, but does not allow the humidified gas to get dried out by the cold, dry gas coming in from the vent. And typically, most hospitals start with these because a non-heated circuit is less expensive. And the HME manufacturers will say that they're just as good. There is some recent data coming around that says that we should just be using heated humidified systems for VAP prevention and VAP prevention. Ask your preceptor if you haven't heard of it. VAP prevention is ventilator-acquired pneumonia. And so hospitals are tracked by this, and we have to report any ventilator-acquired pneumonias that we're allowed to develop. And so we have what's called a VAP bundle. And I guarantee whatever hospital you're going to, for your clinicals, has a VAP bundle. They are oral care every 1 to 2 hours. We like to keep those patients at least 30 degrees above horizontal. We do daily weaning trials to try and get them extubated or off the vent. We don't break the circuit like we used to in the old days. We use subglottic suctioning to keep the secretions off the cuff, all those things, so that we can prevent ventilator-acquired pneumonias. It's all money well spent because one ventilator-acquired pneumonia can blow your budget for the entire quarter, trying to treat them with antibiotics and increase patient days on the vent. So it's a big deal. And there's some data suggesting now that we just need to keep them on a heated humidified circuit and not even break the circuit 3 days into it to put them on a heated system versus this HME. So that might be the new best practice. We'll see over the next year or so what hospitals start to elect to do if they haven't already. Irregardless, this device isn't a heater humidifier, but more of a preventer from letting the patient dry out, keeping the patient from drying out. Okay, so kind of a quick overview of heating and humidified and oxygen, of providing humidified gas to our patients. As with any past weeks, I encourage you to look for this stuff in your clinical time. Ask your preceptors, ask the other RTs as you're in the department. Take a walk up the ICU and see what they're using, how they're using it, what brands there are, just so you get some exposure to that. And then at that point, if you have a question for me or want to talk about it in your discussion, please share with us and let us know what you found. Just wrap things up, make sure that your physician interaction forms are getting taken care of over the next couple of days. Let me help you with that. If you have an issue, Annalise is around as well, and she's a whiz at it. She's awesome. She's a huge help to facilitate that and make it work for us. So get in touch with me, email me, whatever, and let's make sure we get that in as well. Hope you've enjoyed tonight's lecture. You have a good night and enjoy your clinicals this week, and post in your discussion. Let us know so we can learn and share together. With that, thank you. Have a great night, and we'll talk to you next week.